and welcome to the EMSNation podcast. I'm your host, Faizan Arshad. Today has been such an exciting day where we've had the privilege of exploring such complex issues, nuanced critical care, and really digging into those complex scenarios where as critical care providers, we have the opportunity to make a significant difference in our patient care as well as patient outcomes. So without further ado, we have assembled a brilliant panel of physicians, paramedics, nurses, and overall critical care providers to debrief the day and bring you some of the salient points from CCTMC 2018, Day 2.
I'm Cynthia Griffin. I'm a flight physician with UW, and I'm at CMG RFFN.
I'm Chris Fullagar. I'm a flight physician and a paramedic from Syracuse, New York, and past president of AMPA, and I am at 87 MD1.
My name is Matt Roginski. I'm an emergency medicine and critical care physician who works with assistant medical director at DART, and I'm at MATTROGINSKI.
Hi everybody, I'm Andrew Latimer. I'm the Associate Medical Director and Flight Physician for Airlift Northwest at the University of Washington, Seattle, and I'm at A Latimer 13.
Hi, I'm Chuck Sheppard. I'm a ER Doc Medical Director at Mercy Lifeline in Springfield, Missouri, and I'm at Chuck Sheppard, CHUCK-SHEPPARD.
Hey all, Sam Matta, flight nurse and critical care transport nurse for University of Maryland at Luigi's dad.
Hey, Ashley Liebig here. You know me at Ashley Liebig, flight nurse, rescue specialist, Travis County Starflight.
Hey, Bill Hinckley, retrievalist, UC Air Care Cincinnati, and I'm at UC Air Care Doc.
Michael Berrier, flight paramedic with Vidant East Care, Greenville, North Carolina. I'm at CRIT_CARE_EXEL.
Let's get it on. So, Chuck Sheppard, you opened up our morning general session, Are We All Deviants? Normalization of deviance, and you had the opportunity to explore sort of decision making. When do we do what we're supposed to do? When do we not do what we're supposed to do? And the overall implications to our patients.
Yes. What I was trying to get across is how easy it is for us to move normal. We start out with a given safety margin, but if you're not careful, you move your safety margin and continue to make it smaller until a disaster happened. The example I used was a Challenger crash, which was the best example I could find of how this process worked and what a danger it is to us and our patients and our flight crews.
Chuck, I walked away from your talk feeling particularly lazy. And I think we all did, because you brought up the point of how all of us inherently have a lazy brain, and we have to just constantly fight against that tendency which we were born with. But the other point that really struck me is when you brought up the fact that you're people that are perhaps at highest risk of normalization of deviance may be your best performers, because they are the people that are not going to be called out by the other members of the team. And so that's one I'm definitely going to walk away with.
I think just looking around the room here, it's probably pretty safe to say that we are all deviants here. But the thing that really kind of hit home with me was this level of acceptable risk. I mean, we all take risk in everything that we do, and we usually put a line in the sand as to what is acceptable a level of risk and what is not. And the issue comes in which whenever that line is crossed, if that's not at least brought up and discussed, then that becomes the new normal. And slowly over time, that line in the sand seems to migrate. And especially, as Bill just said, when there are people who are the most senior people in the organization that are doing it, then it seems as though that becomes okay. And it's the old adage about how do you boil a frog? You just turn up the heat very, very slowly. And sooner or later, a catastrophe occurs. And I think that's what we all have to be very cognizant of and continually monitoring ourselves and our colleagues to make sure that we don't walk down that slippery path.
So what are some of our tactical points that we can take away and incorporate both into our individual practices and as medical directors into our organizations to sort of address the inherently lazy brain of the individual?
To me, the key thing that you have to do is try to instill in the people you work with that even if it's you getting away with something, you shouldn't be allowed to do that. That a deviation should always be at least discussed, brought up, and as I said, you have to make a decision. Was the deviation for a good reason or maybe a lousy rule, or did it really put people at risk, in which case you need to back that line in the sand up to what you decided in the beginning was the acceptable risk. Because the only time this works is when it's a low frequency bad outcome. If in fact every time you deviated you had a bad outcome, you wouldn't do it. It's when you can deviate and get away with it that you start moving the line in the sand. And that's the high risk.
I think it's virtually impossible to do anything about this if you as a leader are not out there in the trenches with the crews, doing your best to set an example and asking them for feedback of when you make a mistake. You know, for instance, last week I'm on the aircraft, we've lifted off, and I realize, 2 minutes into the flight that I didn't strap my chin strap. And so I asked my partner, hey man, why didn't you call me out on that? But that sort of thing can't be done if you as a leader aren't out there with the team on a regular basis.
Fantastic. I think for organizations that have a non-punitive approach to dealing with errors that may occur in patient care so that they can be dealt with in a constructive manner, certainly, go a way to sort of create a culture where reporting mistakes or reporting errors, at least on a conscious level, can be done in a safe way.
Absolutely. If your crews or whoever you're talking about in your organization feel like when they report somebody, that person is in trouble, it's never going to work. Because nobody is, A, going to report a senior person and get them in trouble, nor are they wanting to get their friends in trouble.
Faizan, I feel like this is a really good opportunity to kind of hop ahead a little bit into Mike Frake's talk today when he started talking about organizational knowledge gaps. And for me, this was extremely important because I think our future is going to be in video recording and audio recording of our aircraft, of body camera use and that sort of thing. From our experience, yes, we absolutely think our providers are out doing the very best that they can. And we think we are doing the very best we can until we watch ourselves played back on video, which has been proven time and time again on simulation. And for us specifically, it has been proven time again on hoist camera or our winch camera, where we think we have done something, we think we have given a certain signal or said something, and then that was proven to be incorrect. And so I think we always think we're a little bit better than we are. And I'm interested in some of the folks and what they're doing with recording devices in their aircraft and with regard to patient care.
Yeah, I'll jump in here. This isn't really on the aircraft just yet. We're working on some logistical issues with this. But with the Seattle Fire Department, with Seattle Fire Medic 1, every time you turn on one of our monitor devices, we're currently using the LifePack 15s, it starts a microphone and recording. And we actually save and process all the downloads for audio recording and again, all the code stat recording. So we get 3-lead tracing, SpO2 pleth, and tidal pleth, in time with audio for every out-of-hospital rapid sequence intubation and cardiac arrest, and we have the crews debrief them. And it is really telling to be able to identify maybe some hypoxia that occurred that the crews didn't even know about because they were task saturated, and it's really changed our process and how we're able to take care of these critically ill patients. And I think it's definitely been better for patient safety and made the program better.
Latimer, I got to ask, did you run into any contractual or union issues in setting up that sort of a thing?
We haven't had any big union issues, but that's definitely a question that comes up routinely. It definitely depends on the state you're in. So in the state of Washington, this is all protected under QI, and it is rock solid. It's actually been challenged in court and has been supported, and all of it is used for non-punitive QI, totally non-discoverable. And every state has some different laws. I know in the state of Oregon, for example, it is not that case, but they're actively changing the law there. And it turns out it's pretty easy to convince state lawmakers on this. There's been a couple of states, I don't know off the top of my head, that have successfully challenged these laws and gotten them changed to get this information QI protected so that it can be used to improve patient care.
That's definitely a relevant point. I think a particular state that can be concerning for our patients is the state of hypoxia. And positive end expiratory pressure is a strategy that we can employ, and I think it would be fair to say that we underemploy in the current day and age to optimize our patients' pre-oxygenation and oxygenation overall.
Can we just take a moment to appreciate that seg? Because that was awesome.
The master of segues.
Yeah, where this talk came from today about what eventually we ended up calling Making PEEP Great Again, I know you're going to talk about the t-shirt, was the idea that I wanted to educate more people who didn't know about PEEP about it. And then it got picked up to come here, and I realized I was going to be in a room full of people who knew what PEEP was, so I couldn't really do that. And so I knew I didn't have to spend a lot of the talk talking about what PEEP was, and instead talking about some things that mattered. And so then it was a question of deciding what mattered. And that's how I came up with the 4 questions that we talked about today about is physiologic PEEP really a thing? Should we be clamping the ET tube when we break the vent circuit? Is PEEP resulting in the hypotension that we think it is? And is zero PEEP ever okay? And when doing that, the very first thing I found, as I pointed out today, was that a deep dive on the literature is actually pretty shallow because it's not there. A lot of the literature is based on ARDS and what our proper PEEP setting should be for that and for driving pressure and things like that. But if you want to get into the other 95% of the patients that don't have ARDS, the literature is virtually non-existent.
So, Mike, you brought up the question, what the heck do I do if I know I should be using a PEEP valve right now, but I don't have one? And the thing that jumps into my mind is just freaking get one. They're not that expensive. But in the heat of the moment, that takes time. So you brought up my mind was blown when you brought up your solution of putting a piece of tape over the exhalation port and then essentially incising that tape with about a 1-inch incision with a scalpel. Tell us about the moment of inspiration when this came to you, because that must have, were there angels involved? Or?
It was a lot of boredom and free time, and just I had rigged up the setting where I could test our PEEP valves and see if they were accurate, and that's when I began to understand what our PEEP valves and what even PEEP on the ventilator truly was, which was just outflow obstruction. And so if we just need to block outflow obstruction, that's pretty simple. And so I was trying different things and putting my hand over it and stuff like that. And then I've got a drawer full of tape, I'll give that a shot. And I put that over there and cut the hole in the middle and ran the same test. And it came up that provides a pretty predictable amount of PEEP, at least in that particular bag valve mask. And so that's where that came from.
So did you use duct tape? I got to know if this is another solution for duct tape.
I think it certainly could be. What I had on hand was 2-inch silk tape, which worked really well because of the size of that exhalation port. But I think pretty much any tape would work. I actually looked at making some little pad or something that would just do it kind of in a measured way. But that solution worked really well, and I was really happy with that.
Mike, what's your approach to teaching about the physiology of PEEP to your providers? Because I know when we discuss intrathoracic pressure regulation, it's an incredibly difficult concept to teach because it's invisible. So how exactly do you go about teaching PEEP to folks who don't really understand what it is?
The easiest way I do it for people at a ground level is that I explain that during the respiratory cycle, when you set a PEEP on the ventilator or the bag valve mask or whatever, that PEEP becomes the new zero. That's the lowest the pressure is ever going to reach. And so whatever pressure is left over, that's the amount of pressure that we can assume is going to be communicated throughout the thoracic cage. And so if you have issues where that amount of intrathoracic pressure is going to be an issue, then that's what you take into consideration, is that the pressure is never going to get below that. And so you can't expect any relief beyond that. And of course, as we prove through the tiny amount of literature we have, usually high PEEPs aren't going to be that big of a deal unless somebody is grossly hypovolemic, in which case then turning the PEEP down is usually not the answer. It's fixing the volume problem or the blood pressure problem.
I think that was one of the main takeaways that I have. I mean, we oftentimes will think of PEEP as thereby producing a change in the right ventricular end diastolic volume or the right ventricular ejection fraction, and kind of blaming hypotension on the PEEP itself. But as you mentioned, and one thing I think that's important to keep in the back of the mind is that if you have a patient who is hypotensive and you think it's due to PEEP, you may be missing something else. So keep that in mind. And
especially if it's normal varieties of PEEP. And one of the conversations I had after the lecture was over was that I wish I could teach people to be more fearful of oxygen and less fearful of pressure, because that's often going to cause way more problems, whereas we know now, of course, we can accept much, much higher PEEPs without doing either lung damage or hemodynamic damage, but our issues with FiO2 are persistent and costly.
I think that segues well to the chat that I gave this afternoon on pre-ox, apox, and reox during the RSI process in critically ill patients. The typical teaching I had was there are essentially two variables that you can manipulate in order to improve or optimize your pre-oxygenation of patients prior to RSI. And of course, pre-oxygenation requires oxygen. So having high inspiratory flow rates of oxygen using methodologies that we know are going to also maximally denitrogenate that patient are certainly effective. And I think for the majority of folks, the reason the literature has been so mixed or non-supportive of the practice of APOX is because pre-oxygenation has been excellent, number one, in the studies that have looked at the ED and critical care population, and two, the overall laryngoscopy times have been low and first pass success has been high. So really when you look at has APOX been tested in the studies that were aiming to test APOX, I'm not quite so sure that they did. So in that patient where you don't get a saturation of 100% before you administer your RSI meds, I think there's opportunity for improvement using apneic CPAP, some other interventions to recruit those alveoli, pop them open, and to prevent the de-recruitment during the apneic period.
I think changing and bringing the focus to, if you do have a shunt physiology, of addressing that shunt is huge, because I think in a normal healthy patient that doesn't have primary pulmonary disease, you can put a non-rebreather on and not have an issue. But in a lot of the obese, critically ill, pneumonia, early restrictive lung disease folks, that this doesn't work. And I think it's the reason that we're not making that cognitive jump into addressing how do we change the shunt fraction, and then how do we change the functional residual capacity, whether that's in an obese person sitting up more, increasing my PEEP, increasing or improving my cardiac output, and then trying to optimize my intubating conditions, whether that's applying a CPAP, applying a BiPAP, or a non-invasive mode on the ventilator, to really try to optimize pre-intubating conditions before just pushing paralytics.
Faizan, one other really specific and useful clinical point that you brought up that a lot of people actually don't know is that if you're going to be doing APOX with a nasal cannula, you cannot successfully use a capnography cannula for that. Many physicians that I know are not aware of this. So you got a capnography cannula, it's got that little Adolf Hitler's mustache looking thing. That's where the oxygen comes out. It does not come out through the nasal prongs. The nasal prongs are only for CO2 sampling, and so you're not going to be successful at doing APOX with a capnography cannula. And thank you for reminding us of that.
I want to thank Dr. Chuck Sheppard, because I threw that slide in at the last minute, because he, as a medical director, was like, this is a point that we need to emphasize, and I 100% agree.
Yeah, and I learned that on EMSNation when I listened to Jarvis's talk about oxygenation. So yeah, I thank you very much for that.
Talk about full circle.
Yeah.
Speaking of full circle and getting ourselves into pickles and out of pickles, the current state of coagulation in America for various conditions is incredibly complex. both on using potential modalities to reverse coagulation, and then also testing the degree of coagulation, whether in the air, out of the hospital, or in the hospital. And we had several talks which addressed those challenges today.
So this morning, I think you just mentioned it in passing, and yet to me it was like dropping a giant bomb on CCTMC, was Mike Frakes when he mentioned, in a couple of months we're going to start flying a TEG machine around on Boston Med Flight. And he just mentioned it in passing and moved on. And I was like, what? So talk about pushing the limits. Now, none of us know if this is going to work. And to be clear, I talked to Mike afterward, and they're not going to be using it on patients at this point. They're doing a feasibility study, apparently drawing crew members' blood and then testing it on a TEG machine and to see if you can actually do this and get legitimate results in the air or not. But talk about pushing the limits. That's pretty exciting.
Can we just potentially define exactly what TEG is and what the theoretical indications are for its implementation?
No, sir, I cannot.
Any critical care doc in the room?
So TEG is trans something other, electrocardiogram.
Thromboelastogram.
Yeah, there you go. But it's a way to look at clot formation and clot degradation. You put clot in this little thing that's got a spinning. There are two. There's one in Europe too, which is a different.
One's TEG, one's Rotam.
Yeah, Rotam is the other one. But it essentially tells you whether the patient needs more platelets, more coagulation factors, less fibrinolysis, which then allows you to tailor your therapy. So you give them blood, you give them platelets, you give them TXA or trauma has been the ones all over this, at least at my hospital. So that we're doing TEG in the emergency department and using that to drive. Instead of everybody gets 1-to-1-to-1, the patient whose clot's degrading too fast gets antifibrinolytic TXA. The patient who is not clotting fast enough gets platelets and coagulation factors. But I mean, that's essentially what it does. Allows you to tailor your replacement to what's missing.
And the idea of doing it in the air is kind of exciting because this is really tip of the spear kind of stuff. Because in our place, when they first started doing it, they put arrows on the wall so that whoever was running it to the lab wouldn't get lost. Because you had to do it within 10 minutes of drawing the sample. And so the idea of doing it 10 seconds after you draw the sample is pretty groundbreaking if it works. So I think it's great what they're doing.
Yeah. And we moved it to our emergency department just for that reason, that it has to be done right away.
Speaking of groundbreaking, occasionally we have trauma patients that break the ground, who are on anticoagulation and need to be reversed. We were very excited to meet for the first time at CCTMC this year, Dr. Damon Darsey. And I know we have a lot of questions lined up for you. So let's get it on.
Hey guys, good evening. Damon Darsey, Medical Director of University of Mississippi Air Care in Jackson. Emergency physician by training, peds and adult.
So where did this topic come from? Why did you guys say this is an area of need that we need to explore, work on, and really deploy in the out-of-hospital environment?
So we have a really forward-leaning team and a great toxicologist and pharmacist, and we realized that they were getting reversed when they got to us. Mississippi's a rural state, and so when they would get to us hours later, we would reverse them. But for what? We were minutes to hours later. And so the question became, how do we move instead of the patient to the care to the patient? And it's a change of philosophy for our guys. It's a change of how we do things. But if we were going to reverse the patient at our facility anyway for a coagulopathy bleed, then why not bring the medicine to the patient and have the testing there and make it happen hours before they get to our hospital.
Can you just walk us through an example of one of the cases that you discussed today and the application and how the logistics of how that would work?
Yeah, so nosebleeds. So who flies nosebleeds, right? That's one of the questions that came up. And the interesting thing about this is our communication center staff with exceptional people, paramedics, EMTs, and they have a protocol that they follow just like our flight guys do. And we learned that, number one, docs don't tell us the truth about what they're on, so no one knows they're on anticoagulants. Number two, the INR is always the forgotten lab. And three, we have these guys that are bleeding out like the nosebleed. that's INR is 9, H&H is 4 and 12, and hypotensive in the 60s. So either we go and we give a whole lot of blood and fly fast back to Jackson, our home center, or to another hospital, or we bring the medicines and reverse the nosebleed there. Give volume, resuscitate them up, reverse the INR within 10 minutes, and bring them back for a stable patient that can be seen and rapidly discharged from the hospital. The alternative is just to fly them real fast to the major hospitals. And then what does that really do for us? So it's three-pronged. Number one, it's screening. Number two, it's testing in flight. 3, it's giving the drug. And 4, it's looking at the outcomes when they get back home.
Can you talk a little bit about what those crews are adding to the aircraft? You talked about vitamin K, protamine. What are the additional resources that are required to manage your protocol?
Yeah, so there's vitamin K, protamine, which people really don't think you need to reverse Lovenox, but we have that more than we can imagine. We have liquid plasma that we carry mainly for volume resuscitation, and we carry a 4-factor PCC that is able for us to give the standard dosing is what we currently use. There's some debate about changing that, but we currently use the standard on-label dosing of 4-factor PCC, and we're giving it a lot. We've done this program since 2014. We've given it over 120 times. We're a busy program, but this is for us leaning forward. And the vast majority of the literature that's out there that we've put out has been in scene flights, which is even more odd. And then really training our first responders, even our state troopers, on asking the question, are you on coagulation? And then reporting that downstream and how that affects us.
So, Damon, just you were mentioning a few things that kind of piqued my interest. One of the things that you had talked about was a bit of a change to the focus on what happens in the back of the aircraft and not how fast it goes. And this is kind of a novel approach to be reversing coagulopathy in the back of the helicopter, but I would imagine that there's a certain degree of at least theoretical risk. Have you come across any bad outcomes from reversing coagulation?
So we're studying this pretty extensively in a couple, 1 published and 3 that are in progress, and we found no instances of thromboembolic events. Now, obviously, if you're flying people with large ICHs that have INRs of 9, the outcomes are probably not going to be great. And so it's hard to look at outcome study when you study this. But from a feature of looking at GI bleeds and trauma and some of the others, we've seen some great successes. Now, again, have we followed them out for 3 years? No. We followed them out to the hospital discharge, but we have not found any there. Some of the other challenges we've had are with cost. And that's a big question, but I challenge those who have that question. You are flying a very expensive airframe with very expensive stuff in it, giving oftentimes blood. And these drugs are expensive for sure, but they're going to be given anyway. Work with your local hospitals that are going to receive these patients. Because again, when you look at the overall cost of downstream revenue, if these patients are getting out of the ICU 4 days faster, 1 day faster, et cetera, which we're beginning to look at that data now, you win. The patients win. It is expensive, but what are we doing? Are we flying patients or are we taking care of patients? 2 very different philosophies.
I think it's important to note at this time that not only are you frequently you are delivering the medication and leaving the patient at the facility so that they stay close to their home and their family, and not billing for if it's not necessary that they come back to a larger hospital or a hub. That essentially those are non-billable patients, and so you're really just doing the right thing for the system and the right thing for the patient. So I think that that's commendable and impressive for the university program to do such a thing.
In isolation, if we only move patients, community hospitals will go away. We've seen that in our state. If we don't build up these guys and girls that work in community hospitals, they're leaving. And our challenge in their medicine is only going to get worse. So instead of focusing on moving patients away from facilities, let's work on keeping people there. Keeping those guys there and supplying the resources. We're very blessed in the university system that supports us that we can do that. But that's where, for us in a rural state, a very poor state, the joke is if we can do it in Mississippi, anybody can do it, right? So I challenge those to look ahead and lean forward because our guys are truly doing this. And it's our comm guys and our flight guys making this happen. It's really impressive to watch.
Thank you so much. That's fantastic, and certainly an example and inspiration to the rest of us. I think that concept really appeals to our audience, is not simply just bringing the patient or transporting them from point A to point B, but really delivering the highest quality care possible and doing the right thing for the patient at the right time. And part of that is exploring the pathophysiology of the patient that may be invisible. And when we talk about high-risk heart disease, right-sided heart failure, these are things which are conceptually difficult to imagine. But Matt, you really brought that to life for us in a way that nobody else has.
Well, this topic really came out of my ignorance during my emergency medicine training, and we'd see more of this during the critical care, and really thinking about silent killers that when we see rapid deterioration during RSI and resuscitation, what the heck happened? And I think two things that I really focused on here was one, aortic stenosis and right-sided heart failure. And I think the pathophysiology of why this kills people is slightly different, but I think the four take-home points that we had were that hypotension kills people quickly, that you rapidly enter this spiral of death. The second part is euvolemia is really important, that you want to not just over or under resuscitate and really be thoughtful about that resuscitation and volume. And then these are two entities where early deploying vasopressors is critically important, and along with treating tachydysrhythmias. And I think this has made me focus on the underlying heart disease of patients coming in, whether they have a systolic murmur, history of right heart failure, and also really trying to think about how I do a normotensive and smooth intubation and what that process looks like.
Speaking of what that process looks like, so Matt, other than active labor in somebody with, twins that are both breech, nothing would scare me more than getting called to pick up somebody with decompensated RV failure, decompensated pulmonary hypertension, and they're clearly sick enough that they need their airway secured prior to transport. How the hell do I pull that off?
Call your friend and send them. I think it's these folks are at exceptionally high risk of dying during induction and in the post intubation phase. And I think every clinician who sees them recognizes that. And you just, I think, drew the short straw of being the one to go get that and insert the tube. So I think the couple things that I first want to take a deep breath and then focus on a few things. This is where if I have the ability, I want to make sure I volume resuscitate them and figure out where that magical euvolemia lies, and also be thoughtful about normotension. And for me, this means if I have the ability to place an arterial line, and a lot of my colleagues rib me because I drank the critical care Kool-Aid, but taking that extra couple minutes, placing an arterial line, and really watching beat to beat to beat, because everybody knows that feeling when we hit the cuff recycle, and it just keeps going. So this is one where if you have the ability to take that time, place an arterial line, or cycle that cuff every 1 to 2 minutes, and really optimize your pre-intubating conditions. And I think the second is being thoughtful about your induction method. And this, while most of us and most people can get their, pick your induction agent of choice, your paralytic, the tube's in, you're off, and you dutifully prescribe the right amount of PEEP. But I think this is one where picking a hemodynamically neutral induction agent, and there's lots of argument depending on which cocktail you subscribe to, but I think something like a lower half dose etomidate, or I personally use a little bit of fentanyl, a little bit of Versed, wait to see how it comes to effect. The person gets a little more drowsy, and then kind of edge them to that goal of going off to sleep, and then push the paralysis. And then hopefully the intubation goes smoothly, and then the real work begins about post-intubation care, which is preventing things that cause an increased pulmonary vasoconstriction. So really making sure you avoid hypoxia, hypercarbia. Don't give phenylephrine because that increases your pulmonary vascular resistance. And then 6 to 8 cc's per kilo and a low amount of PEEP to decrease that pulmonary vascular resistance. So I think these are exceptionally difficult patients to manage and have a spectacularly high mortality rate. but I think are terrifying and exciting all wrapped up into one to really be that resuscitationist.
Yeah, and Matthew, I think one of the things that I try to convey to people who do that is one of the differences between a new provider and an experienced provider is that the new provider knows what to do right then. They know the algorithms, they've gone to school, they've got the medical care down, but the experienced provider knows what's going to happen down the line. So they can anticipate problems. They will be able to be right on top of complications because they have the experience. They've seen patients. These particular patients that are preload dependent, as you mentioned, are extremely challenging. And, the approaches to that are, as you mentioned, about making sure that you address hypotension, target euvolemia. And one of the most important things is to have that norepi in line, have the norepi ready to go. That's not the time when you want to be going back to the Pyxis or trying to figure out where that is in your aircraft and trying to hang it. You know what is going to potentially happen to these patients, and it can occur very quickly. And lastly, you had mentioned to treat tachydysrhythmias very aggressively as well, particularly with aortic stenosis. Those coronary arteries they arise just past the aortic valve. So these people are at risk. To be able to use the stethoscope, which is a device that we once used long ago, to check and see if that patient has a murmur. And if you happen to be able to have access to the chart, do a chart review. See if these patients have critical aortic stenosis and be ready before they start to decompensate.
That's really been my favorite part of this conference, is exploring those incredibly medically complex patients, probing the nuances, digging in, and as a community of critical care providers, working together to optimize and deliver the highest quality of patient care, regardless of where we find that patient. And for those of you listening at home who have serious FOMO, fear of missing out, for CCTMC 18, we have an exciting announcement about CCTMC 2019.
So CCTMC 2019, be there or be square. We will be in Albuquerque, New Mexico, and we'll actually be there for the next 2 years. It'll be at the Hotel Albuquerque, oddly enough. And again, those dates are April the 15th through the 17th, 2019. I cannot wait.
Mark your calendars, folks. This is Cynthia Griffin, Chris Fullagar, Matt Roginski, Andrew Latimer, Chuck Sheppard, Sam Matta, Bill Hinckley, Michael Berrier, Ashley Liebig, and Dr. Damon Darsey, wishing everyone a safe tour.